तो आपकी आवाज बहुत स्लो आ रही है।
स्लो आ रही है। Today we are going to discuss the examination of neonate. And so first of all, our objectives: perform a neonatal examination. Now, before moving to the neonatal examination, we will first have to there are few prerequisites, like every baby should be examined. And so these are basically what is the purpose of a neonatal examination. You see, this is the first newborn examination, and it should be very thorough and very appropriate, and one should not miss anything because otherwise it will be harmful for the baby in the entire life. So every baby should be examined, and it helps to reassure the parents, and we can identify defects for early intervention, and it also serves as a baseline for subsequent follow-up visits. Now, what are the timing of examination? So the first assessment should be within the labor room. As soon as the baby is born, the first assessment should be done there, ideally by a pediatrician or a pediatric resident should be there to assess the baby. Then the second assessment should be within first 24 hours of life, and the third assessment before discharge or within first week of life. What are the prerequisites for a neonatal examination? Ideally, mother should be present, and if mother is not available because of some reason, or mother is probably ill or she's bedridden, in that case, any caretaker should be present. The room should be warm and well lit, and you have to wash your hands properly before touching the newborn. And before going for examination, you should be asking for a brief history. And first, so I will discuss few points about the neonatal history. As you know, in the history taking, there is some difference between the adult and the pediatric history taking. And in the pediatric, when we take the history in pediatrics, we have some additional clause like birth history, developmental history, feeding history, and these things, and we have to be very these things should be elaborated. And in case of neonatal history, the birth history should be very well elaborated. So first of all, we'll ask the presenting complaint, like what is the presenting complaint, why the baby is presented to us. If it is just the well-being examination, like the first assessment or second assessment, then it's okay, we don't need any history. But even in that case, birth history is important so that we can examine the baby according to that. So the history is very important. And the common presenting complaints in case of newborn, the patient can present with yellowish discoloration of the body. The baby is not feeding well, or he's lethargic, he's too much sleepy, he has not passed urinal stool, or he's passing more stools than usual, or the breastfeeding he's not taking breastfeed properly, or the baby has fever, the baby has fits, he's reluctant to feed. So these are the common presenting complaints. First, you have to ask the presenting complaints. Then, secondly, history of presenting complaint means you just elaborate the presenting complaint. And for example, if the baby is presenting with yellowish discoloration of the body, then you have to ask at what time of the birth the jaundice started, because you have to rule out whether it is a physiological jaundice or pathological jaundice. So remember, the jaundice that presents within first 24 hours of life is always pathological. So the timing of appearance of jaundice is very important. Then you have to ask what is the color of the urinary stool and extent of the jaundice. Is there any other symptoms like associated fever or associated fits, any posting, any abnormal movements, any shortness of breath? So you ask all these cases and elaborate the history of presenting complaint. This is followed by birth history. The birth history further has three components: antenatal, natal, and the postnatal. So in the antenatal history, you have to ask whether the mother was a booked case or not, means she is visiting any gynecologist or any hospital or not, whether she is taking any multivitamins, any other drugs. Is there any history of pregnancy-induced hypertension, pregnancy-induced diabetes, or any other chronic maternal illness? Because all these things have an impact on the newborn baby and the underlying fetus. Then you have to ask if the mother has received any vaccination, like usually give tetanus vaccine in the third trimester. So you have to specifically ask for that. And then comes the, or does she require any infection during pregnancy? And then in the natal history, you have to ask whether it was a full-term or preterm delivery. It was a normal vaginal delivery, mode of delivery like normal vaginal delivery, assisted delivery, cesarean delivery. If it was a cesarean section, then whether it was emergency cesarean section or a planned cesarean section, and then what was the cause for that emergency or the planned cesarean section. Because all these questions are very important, because in cases of emergency cesarean section, you should anticipate that the baby may present with any symptoms of shortness of breath or any other symptoms, and he or she may need neonatal intensive care. Because most of the time in cases of emergency cesarean section, the fetus is under distress, and you have to be very careful in examining the newborn. So in the natal history comprised of all these questions. Then comes the first of all, you have to look for any dysmorphic features. And in the dysmorphism means that any features that are abnormal as compared to the normal facial features. This will be like a depressed nasal bridge, abnormal eyes, abnormal head shape like microcephaly, any abnormality of ears, any cleft lip or cleft palate. So these are all dysmorphic features. So they can be visible just as a simple inspection. Then you have to see the activity of the baby, whether the baby is active or lethargic or any abnormal posture. So the normal posture of the baby this is the normal resting posture of the newborn, in which he has kept flexed his arms and legs in partial flexion. So this is the normal resting posture of a newborn. So if there is any abnormality in the posture, that could be identified. It could be abnormal extension, abnormal flexion, arching of the back. All these are, or the child is having any abnormal activity like seizure activity, then it should be seen in the inspection. So after posture, the color of the baby, whether baby is pale, pink, or cyanosed, any signs of respiratory distress should also be looked for in the first inspection. Then comes the vitals. In the vitals, we have to look for the count the respiratory rate, heart rate, and the temperature. The respiratory rate in the newborn ranges from 40 to 60 breaths per minute long, and you have to count this respiratory rate for complete 60 seconds. And the heart rate ranges between 120 to 160 beats per minute, while the temperature is between 36.5 to 37.5 degrees centigrade. So these are the normal vitals of a newborn. Anything that is not within this range is considered as abnormal. Then the anthropometry measurements like weight, length, and FOC of the baby. The normal weight of the baby should be more than or equal to 2.5 kg. The time 2.8 is actually 2.5. So please correct it. It is 2.5 kg. If the weight is less than 2.5, then the baby is considered as low birth weight baby. Length of the baby should be within it's 50 centimeters, while the FOC ranges between 33 to 35 centimeters. Now you should know that how to measure these, how to take these measurements. So this is the weight measurement. This is the weighing scale that is being used for the newborn weight measurements. And this is digital, and the manual machines are also available. So in this way, you can measure the weight of the baby. This is the infantometer. This is basically not height, actually. This is the length. Because since the child is not standing, baby is not standing, we are taking the lying posture. So it's actually the length measurement using the infantometer. So this is the infantometer, which is used to measure the length of the babies, and you have to keep his two ends, one at the head end and the other at the foot end, and you just measure the length in centimeters. This is the FOC measurement, or the head circumference measurement, and we have to mark 2 points, 2 landmarks. One is the on the front, this is glabella, just between the 2 eyebrows. This is the this is called the glabella. So 1 point is glabella, and on the posteriorly, this is the posterior occipital protuberance. This is the most prominent part over the back of the head, and so this is your second landmark, and you have to encircle the inch tape around these 2 landmarks and measure the head circumference. So these are the methods by which you can take the anthropometry of the baby. Now we come to the proper head-to-toe examination, and this is the pattern of examination in a newborn, in which you have to look for from head to toe. So starting from the head, we already discussed the FOC measurement, then the shape of the head, then fontanelle, sutures, and layers. So we come to it one by one. Okay. So we have to see whether the head shape is normal, molded, or if there is caput. And in the abnormality, if there is any cephal hematoma, subaponeurotic hemorrhage, hydrocephalus, microcephaly, or any abnormal head shapes. Okay. So this is the normal shape of the head, which is elongated in the front, slightly broad at the back. Now, this is the caput succedaneum, and the caput is basically a swelling, which is it's basically a collection of the blood at the presenting part of the head, and it actually happens around the skull, which give an infantile head appearance, and it usually forms after a difficult delivery. Caput, remember that caput occurs only in cases of vaginal delivery, or if in case of cesarean delivery, if the trial of the labor was given and there was any obstructed labor, and then the patient end up with the cesarean delivery, even in that case, the caput may be there. But if it is a planned cesarean delivery, then the caput is usually not there. So caput actually happens because whenever the mother pushes the baby against the presenting part, touches the pubic bones again and again, and there is some trauma to the underlying bones, and there is collection of the blood. So this is usually caput is a swelling which is present at the presenting part, and usually subsides within 7 to 10 days. And nothing, you don't have to worry about it. It's usually unilateral. It is limited. Sorry, this is a cephal hematoma. So caput is usually self-resolving, and unless it is very large, you don't have to worry about it. It usually resolves by itself within 7 to 10 days. Then comes cephal hematoma. So how to differentiate between caput and cephal hematoma is that the cephal hematoma, because it is a collection within the underlying bone. So it is usually limited by the suture lines, because there is hematoma underlying the bone. There is subperiosteal collection. You can see this cephal hematoma is marked by it is not continuous. It is marked by the suture lines. So they are usually unilateral, limited by suture lines. They cannot, these swelling of cephal hematoma won't cross the suture lines, while caput does. And it may be associated with underlying fracture. It usually resolves in 2 weeks to 3 months. You have to monitor for anemia and hyperbilirubinemia. The breast fractures require immediate consult. The third mode swelling, or another important collection, is the subaponeurotic hemorrhage, and it is the most serious one, because in cases of subaponeurotic hemorrhage, there is what happens that it is also called subgaleal hemorrhage, and it is defined as bleeding beneath the gallia aponeurosis covering the scalp. As the gallia aponeurotica layer of the scalp is continuous across the scalp, bleeding in this layer may extend across the entire cranium, and it can cause obstruction of the major vessels. This type of bleeding can be extensive and life-threatening. Clinically, this condition presents as fluctuant mass that cross the suture lines in the scalp. So we have discussed 3 swellings: caput, Cephalohematoma and subaponeurotic hemorrhage, and this, I've told you that the most serious one is the subaponeurotic hemorrhage. Capitment, you don't have to worry about within 7 to 10 days, while cephalohematoma takes 2 weeks to 3 months, and sometimes when the collection is large, you can anticipate anemia and hyperbilirubinemia. Now comes to the fontanelles and the sutures. So normally there are 2 fontanelles, anterior and the posterior fontanelle, and they are usually open, flat, and concave. If there is any bulge or they are less than small or large, then these are considered as abnormal. So first you have to know this is the scalp view, which is showing the anterior fontanelle and the posterior fontanelle. So anterior fontanelle lies at the junction of the coronal and the sagittal suture. So this is the sagittal suture and this is the coronal suture. And the anterior fontanelle is diamond shaped and it is at the junction of the coronal and the sagittal suture. And this is the posterior fontanelle. Posterior fontanelle lies at the junction of the sagittal and the lambdoid suture. So these are the normal scalp anatomy. In this anterior fontanelle, you have to look for any bulging or any, there is abnormally large anterior fontanelle or abnormally small. If it is more than 4 centimeter in diameter, then it is abnormally large. And if it is bulging, then there may be underlying fluid collection or hydrocephalus. So you have to look for it. Then comes the craniosynostosis. Craniosynostosis means that there is premature fusion of the sutures. There is distorted shape, and the anomaly suggests a genetic disorder. And surgical intervention is required if there is hydrocephalus or restricted brain growth. Now, what happens that normally you can see these are the suture lines, and there is a slight gap at the suture line. You can when you feel the head of the newborn, these suture lines are feel as a gap between the 2 bones, so that they help to grow the skull bones. But what happens in case of craniosynostosis? There is a premature fusion of these sutures, and this restricts the brain growth. And the restricted brain growth sometimes results in there's microcephaly or there is underlying hydrocephalus. So whenever there is craniosynostosis, you have to look for underlying genetic disorders. Certain symptoms are associated with it, and surgical intervention is sometimes required if there is hydrocephalus or restricted brain growth. You can see here, this is the normal, in which the brain growth is, the suture lines are open, and as the bones expand, the head shape is normal. But here you can see this sagittal suture has been closed prematurely. It can be felt as a ridge over this suture line, and when this happens, what happens? The shape of the head is distorted. So after head, we come to the eyes, and in the eyes, first of all, you have to look for conjunctiva or sclera, and normally it should be pale pink. Sometimes subconjunctival hemorrhages can be present, and watery discharge from the eye is also sometimes considered normal. Now, what are the abnormal signs? If there is any inflammation, the discharge is colored, or if there is any edema of the eyelids, or there is excessive lacrimation. So these are considered as abnormal. These are the subconjunctival hemorrhages. They are usually normal in cases of normal vaginal delivery because of the pressure to the subconjunctival vessels within the eye as the baby passes through the birth canal. So they are sometimes considered normal, unless associated with any abnormal discharge or any other signs of trauma. This is the crusting and the colored discharge from the eye. Then come the pupils. Normally they should be clear, round, red reflex, and equally active. If there is any opacity that reflects, then this is considered as abnormal. What is the red reflex? The red reflex refers to the reddish-orange reflection of light from the back of the eye or fundus observed when using an ophthalmoscope or retinoscope. The red reflex is considered abnormal if there is any asymmetry between the eyes, dark spots, or white reflex. White reflex means there is any opacity and you cannot see the red reflex. Red reflex is usually observed on ophthalmoscopic or the fundus examination. This is the corneal opacity or the congenital cataract, which appears at the white opacity within the pupils. So after the eyes, we come to the ears. Normally, they should be equal size and curvature. Meatus should be patent and reacts to sound. Abnormal is considered abnormal if there are unequal ears, any deformations, low set ears, no reaction to sound, any tags or sinuses. Now you come to one by one. Okay. So in case of the premature babies, the cartilage is small and pliable. So it seems like this. This attach, it is very soft and it's usually sticky to the head side. While here you can see the cartilage is well formed. This is a firm ear, well formed margin. These are some deformities of the ears. Hypoplastic auricle. This is a low set ear. Now, how can you say this is low set ear? You have to draw an imaginary line from the inner canthus and should cross the. This should be straight line. You follow this. Okay, so you have to make an imaginary line across the inner canthus or medial canthus of the eye, and if the upper 1/3 of the auricle lies above this line, it means that this is normally set ear. But here you can see all of the auricle is below this line. This is the imaginary line which I am drawing, and whole of the ear is below this line. So these are the low set ears. This is the microtia. A very small ear tag is visible. Okay, the well formed. So these are the few deformities of the ear. Then shape of the nose and the patency of the nose. You can see, you have to see whether the child breathes with mouth closed and there is no discharge. Now for the patency of the nose, you can use a test in which you just keep the metal spatula over the nose, beneath the nostrils, and you can see the formation of the mist on the two sides of the nostrils. And if the mist formation is there on both the sides, then you can see that the nose is patent. Other thing is a bit invasive, in which you pass the nasogastric tube, and if it passes easily through both the nostrils, it means that the nostrils are patent. But this is an invasive procedure, so usually not done. Now we come to the mouth. In the mouth, you have to look for the lips, for any cleft lip, movements, for any underlying nerve damage or facial palsy. Then the palate, for any defect or breach in the palate, which is termed as the cleft palate. Then the tongue. In the tongue, you have to look for any macroglossia, microglossia, or tongue tie. Tongue tie is very common. Then teeth and gums. So sometimes in the newborn period, the natal teeth are present, which usually indicates some underlying infection or any other abnormality or any genetic disorder. So you have to look for the natal teeth. Then the mucous membranes and the saliva. So this is the picture showing tongue tie. This is the picture showing a natal tooth. So you see, this is the lower central incisor is there, and this is the natal teeth. And whenever you observe any natal tooth, you have to go for immediate extraction and examine the baby thoroughly, because there are certain syndromes which are associated with it, and there are certain infections like congenital syphilis can present with natal teeth. And if there is no dysmorphism, no abnormal features, no any other evidence of any infection, then in that case it can be left as just a normal finding. And in few cases, can be associated without any other underlying abnormality, and you just have to counsel the parents and go for its extraction as soon as possible, because it can cause ulceration of the baby's mouth, because the baby's mouth is very soft and it is not made for the tooth at that time, at this stage of life. So it can cause ulceration, and it can also hinder during breastfeeding. It can cause trauma to the mother breast as well. So they should be removed and extracted as soon as possible. And this is a picture just showing tongue tie. You can see that the tongue is tied to the floor of the ventral surface of the tongue, is tied to the floor of the mouth, and there is a skin tag here that's attached, and this will obstruct the protrusion of the tongue. The child is unable to protrude his tongue. So you have to identify it as early as possible and to go for the intervention. And the intervention is that you just have to cut this skin tag. And it's a very simple daycare type procedure and outpatient procedure in case. And but if you missed during the newborn period, the child may go unnoticed, and sometimes the child can present with speech delay at the age of 2 to 3 years of age, and that's a very difficult situation, because it was a very simple thing which can be corrected easily, but because you missed it, it has created a lot of problem for the development of the child. So oral cavity should be examined very properly. This is the cleft lip. You can see there is a defect in the normal continuity of the lip, and it means the cosmetic surgery or the plastic surgery. Usually it should be done after 6 months of age, because there is a continuous growth of the lips, and if you do it in the early newborn period, then you may need further surgeries later in the life, because as the baby grows, the defect again and again reappears, and you have to go for the revision surgery. So if it's a small one defect, like in this case, it's a very small defect, and if it's not interfering with the breastfeeding or the bottle feeding, then in that case, you can delay the surgery for 6 to 9 months. Okay, but if it's very extensive and it is delaying, causing any difficulties in feeding, then in that case, early surgeries are considered. So this is the defect within the palate. You can see this is a nasogastric tube which is being passed from the nose, and you can see here through the mouth that there is a defect within the hard palate. So this is the large cleft within the palate, which is termed as the cleft palate. And this is a very problematic thing, because it's a very large one, and it causes the difficulty in feeding. Okay, let me tell you one thing. Sorry, I forgot to tell you in the starting that whatever questions you have, just write it down with you. And at the end of my presentation, I will take all your questions. So this is the cleft palate, which is a large one, and it should be corrected as early as possible, or because it is very difficult for the baby to feed, because as a child feeds, the milk regurgitates through the nose. So this is a complaint in cases of cleft palate, that the mother complains that whenever the child feeds, there's regurgitation of the feed from the nose, because the sealing effect, this cleft palate actually causes sealing effect when the baby breastfeeds, and when this sealing effect is not there, more of the milk comes out through the nasal cavity. So it's a very difficult situation, and the child may go into the recurrent aspiration and aspiration pneumonias. So meanwhile, the surgery is not possible. We have some specialized bottles which can be used. This is the facial picture showing facial palsy. You can see there is a drooping of the mouth on the affected side. And what are the causes of facial palsy? follows the traumatic delivery. Spontaneous resolution occurs in ways, and just you have to prevent the eyes from drying. Apply soap pads over the eyes, and if it doesn't resolve within 2 weeks, then you have to go for the electrodiagnostic studies. Usually, it is self-resolving within 1 to 2 weeks. Now we come to the neck. Now, the abnormalities in the neck are there is webbing of the neck, excessive tissues in the neck, torticollis, or any signs. And this is a picture showing excessive tissues at the neck, and there is a it's not any underlying significant disorder. It could be just because of any hypertrophy babies like infants of diabetic mother use because of the extra insulin, which is an anabolic hormone. It leads to excessive tissues all over the body. So this is there is usually not underlying abnormality. This is a picture which is showing torticollis. What is torticollis? The head of the baby is tilted to one side, and this is because there is some problem within the sternomastoid muscle of the neck. Sometimes any hematoma is there, which could be because of the traumatic. Sometimes there is some fluid collection within the sternomastoid muscle, and which is also termed as sternomastoid tumor, and it leads to this. There is a traction within the muscle because of the collection. It causes the head to tilt towards one side, and the surgical intervention is required for correction of this torticollis. Now we come to the thorax. Normally, the chest should be symmetrical, sternum should be flat, clavicle straight, and the breast bud should be at the mid-clavicular line, and effortless breathing means that there are no signs of distress. What are the abnormalities? If there is any asymmetry, pectus carinatum or excavator, clavicular lump or pain, accessory nipples or dyspnea, or any signs of respiratory distress like subcostal recession, supraesternal recessions, chest and drawing. Okay. In the chest, we also have to look for the precordium. Normally, the apex beat should be within in the fourth intercostal space, just at the mid-clavicular line. Then the precordium should be quiet, and heart rate should be between 110 to 160 beats per minute. Abnormal if the apex beat is displaced. There is prominent precordium. Heart rate is less than 110 or more than 160 beats per minute. If the heart, remember in the newborn, if the heart rate is less than 110, then it comes under bradycardia. Normally we take a cutoff of 60 to 100, and it is less than 60, we say that it is bradycardia. But in cases of newborn, if the heart rate is less than 110, that is considered as bradycardia. When it is more than 160, then it is termed as tachycardia. Any irregularities in the heart rate or any extra sound like murmur, or then it should be considered, and echocardiography should be done as soon as possible. Then we auscultate the chest for breathing sounds, respiratory rate, as I already mentioned, the vital signs that it should be less than 60, and effortless breathing, silent breathing, no abnormal sounds. If the respiratory rate is more than 60 beats per minute, apnea or cyanosis, any signs of distress or noisy breathing, then it is considered abnormal. So after chest, we come to the abdominal examination. In the abdominal examination, the liver is normally palpable 2 to 3 centimeter, and so if you feel a liver margin of 2 to 3 centimeter which is soft, then it is considered normal. A spleen examination method may be palpable normally, and you have to look for umbilicus for any bleeding or infection. And if it's the first newborn examination, you also have to look for the umbilical stump and whether the umbilical is clamped or not. If the thread is tied over the knot or any abnormal thing is placed over the stump, like in case of home deliveries, what they do, because of the unsterilized techniques, they don't use the sterilized clamp, and they just apply a thread or cut it with the knife or any other knife. And what is the risk? That all these things which make the child septic, and it can cause any bacterial sepsis, or there is higher chance of acquiring the neonatal tetanus. And so you have to look for the umbilical stump very carefully, and you have to ask whether it is a home delivery or hospital delivery, because most cases of home deliveries, the umbilical stump is very dirty and thread is tied, and in that case you have to consider the possibility of neonatal tetanus, and you should give the tetanus prophylaxis as soon as possible. Then look for abnormalities like umbilical hernia, gastroschisis, or epilepsy. This is the umbilical hernia, also termed as epilepsy. This is umbilical granuloma, and this is umbilical polyp. So hernia is very clear. Sometimes it's not obvious, and when the child cries, it comes out. Now, umbilical granuloma and umbilical polyp, you can differentiate that the polyp is a very bright red with smooth margins, while granuloma is a serrated margins. So the treatment, both are very benign things, and they can be treated by just cauterization and sometimes excised. So don't have to worry about it. This simple procedures can be done to remove them. Then we come for the examination of limbs. Examine for the signs of fracture, nerve injuries like ups, clumps. Examine the hip for developmental. DDH stands for the developmental dysplasia of the hip joint. And look for abnormalities like talipus equinovarus, syndactyly, and polydactyly. Talipus is also termed as a clubfoot. Okay. This is the Ups palsy, and you can see that this is also termed as the waiter stiff hand or the policeman stiff hand. And you can see that it occurs because of the damage to the brachial plexus, and there is the arm is adapted to the side of the body, and it is internally rotated, and the wrist is flexed. There is flexion of the wrist and the finger. So it's a classic waiter stiff or the policeman stiff hand. And Ups palsy usually resolve within 2 to 3 weeks, just physiotherapy is needed. Then comes the examination for dislocated hip joint. This developmental dysplasia of hip joint presents in the newborn period, and what happens that the hips are dislocated, but because the babies usually lie down, remains in the lying posture most of the time, so it's very difficult to identify. So you have to do these two maneuvers in every newborn baby to identify the dysplasia of the hip joint, and because it should be treated as early as possible to prevent any complication in the future. So we have two maneuvers, Barlow's maneuver and the ortolani maneuvers. Okay. Barlow's and the ortolani. So first, I will explain it afterwards. First, we have to focus on this picture. This is the Barlow maneuver and this is the ortolani maneuver. Now, what Barlow is doing, the examiner adducts the hip while applying a posterior force on the knee to promote dislocation. So basically, he is adducting. He's moving both the thighs close to each other, which is termed as adduction. And in this adduction, what happens? If there is DDH, meaning that if the hip joint is dislocatable, then the head of the femur comes out of the sternum by this maneuver, and you will feel a sound of click-like sound. This should be feel over your fingers, and you can see that this is dislocated. So Barlow's maneuver actually dislocates the dislocatable hip joint. But if there is no dysplasia, then you will not feel any click, and there is no dislocation. Now, ortolani is the opposite of the Barlow. In Barlow, we are adducting the hips. In ortolani, what have we abduct the hips? Now in abduction, what happens now? We are applying pressure at the femoral head, and we are actually relocating the dislocated hip joint. So again, if it is a dislocated hip joint, and when you do this maneuver, you are actually relocating the head of the femur back into the acetabulum, and again you will feel a sound of click. See, examiner abducts the hip while applying an anterior force on the femur to reduce the hip joint. So, in Barlow's, you are dislocating the hip joint, and Ortolani, you are relocating the hip joint. But if there is no dysplasia of the hip joint, then you will not find any sound on these two maneuvers. If you feel any sound, then you have to go for the further investigations of ultrasound and X-rays to confirm the diagnosis of DDH. So now we come to this description that Barlow manual is a test used to identify an unstable hip that can be passively dislocated. The infant is placed in a supine position with the hip flexed to 90 degrees and in neutral rotation. The examiner adducts the hip while applying a posterior force on the knee to cause the head of the femur to dislocate posteriorly from the acetabulum. A palpable clump may be detected as the femoral head exits the acetabulum. So, we are actually dislocating the hip joint by adducting the thighs. The Ortolani maneuver identifies a dislocated hip that can be reduced. So, it's the opposite of the Barlow's, and we are reducing the hip joint. The infant is positioned in the same manner as for the Barlow maneuver, in a supine position with the hip flexed to 90 degrees. From an adducted position, the hip is gently abducted by lifting or pushing the femoral trochanter anteriorly. In a positive finding, there is a palpable clump as the hip reduces back into the position. Hip examination should occur soon after the birth and at every visit until the child is walking normally. This is a picture showing that Ortolani and the Barlow maneuver. You can see here it is dislocating, relocating. The head of the femur is relocating. After that, we will go for the genitalia examination. You have to examine for any ambiguity. Ambiguity means any abnormality within the genitalia, like any abnormality within the genital should be examined. Some babies have testes in the scrotal sac. You have to palpate. In cases of male babies, you have to palpate both the scrotal sacs for testes. If the testes are not palpable, then you will follow the scrotum towards the whole of the inguinal canal, because sometimes the testes are within the inguinal canal and they are in the process of descending and they have not descended to the scrotum. So if you won't find the testes within the inguinal canal, then you can label this child as having undescended testes. In cases of undescended testes, you have to consult the parents and you have to go for the ultrasound abdomen to look for the abdominal testes. And if the abdominal testes are there, you have to just wait for ideally for just 3 months. And if within 3 months the testes won't descend to the scrotum, still in the abdomen, then you have to go for the surgical correction in which you put the testes back into the scrotum, because if you won't do it after beyond 3 months of age, then the testicular damage can happen. And why it is important to make the testes undescended within the scrotum, because you can see the temperature within the scrotum is lower as compared to the abdomen. So if the testes are not descended to the scrotal sac, then the abdominal temperature is higher than the scrotum, and this can cause damage to the sperms and the testes. So the child can be infertile for his life. So you have to be very careful while identifying the testes within the scrotum. And if you identify undescended testes, then you go for the ultrasound abdomen and take the pediatric surgical consult for surgical management. And which ideally you should wait only for the 3 months, and study says that if you wait for more than 3 months, then testicular damage is quite possible. Then check for hernia and hydrocele, and the anal opening should also be checked for pregnancy. This is you can see very large scrotum, and you can observe for the hernia by since it's a newborn, you cannot go for the cuff impulse, so you have to wait for the child to cry. When the child cries because of the pressure, you can feel for the enlarging of the swelling. This is the hydrocele, and this is a trans-illumination test. And since in the hydrocele there is a collection of the fluid within the scrotum and there is no hernia, so when the trans-illumination test is done, you can see there is clear, because of the clear fluid, the light is passing easily through this fluid, and the trans-illumination test is positive. So this is a case of hydrocele. After that, we come to the spine examination, and back is examined for meningocele, meningomyelocele, signs of spina bifida, occulta like lipoma, tuft of hairs, sacral dimple or sinus, and swellings like sacrococcygeal tumors. What is the meningocele and the meningomyelocele? These are actually, this is a picture showing sacral dimple, and if you find any abnormality here, like sacral dimple is there, or any collection of hairs, tuft of hairs is there, or any lipoma here, then you have to go for the MRI spine to look for any abnormality within the spinal cord, because it sometimes is associated with underlying spinal cord abnormalities, and the child can present later on with the developmental disorders. This is the myelomeningocele. Now, what happens? You have heard, I hope that you know about the spina bifida. That in which spina bifida, what happens that within the process of development in the intrauterine life, the spinal cord, there is a defect within the spinal cord, and so it was the neural tube defects. The neural tube won't close, and there is an outpouching of the spinal cord along with the meninges, and this is present as either myelomeningocele or meningocele. Now, in the myelomeningocele, spinal cord also protrudes out, and you can see the nerve endings and within the swelling. And in the meningocele, only meninges are protruded, while spinal cord is not protruded. So, myelomeningocele and meningocele, and if any baby will present with this swelling, you have to go for the immediate intervention, which requires the MRI spine and brain, followed by surgical correction. Because if you won't correct it immediately, it can produce the delays in growth, walking, and bladder bowel problems. Depend on the level of the spinal cord involvement. It could be at the site of the, it could be lumbosacral, it could be sacrococcygeal, like this is probably sacrococcygeal, it could be thoracic, it could be thoracolumbar. So it could be in the and the level of defect will give you clues about the associated developmental issues. So anywhere it is found, it should be corrected as early as possible within the newborn period, because the more you delay, the more defect the child will have. Now we come to the few common skin rashes within the newborn. So this is the erythema toxicum, which these are the common red rashes like prickly heat type, and you don't have to worry about it, and they usually resolve by themselves within 2 to 3 weeks. And this is a milia. And milia is because of any normal collections within the sebaceous glands of the skin, face, and of the skin, and you can see it's the white dots plus with red margins, and this is termed as a typical milia rash, which is very common in the newborn period, and there is no specific treatment, and it's usually self-resolving, and no intervention is required. These are the few hemangiomas, also termed as salmon patch, capillary hemangiomas, and which is visible like this. And, again no intervention is required. Unless if it is on the any facial side, then cosmetic surgery may be required, but usually you go for any intervention. These are the birthmarks or the Mongolian spots. So again, they are normal, not normal, but they are termed as birthmarks or the Mongolian spots. And they are quite prevalent. You might have seen these type of marks on a newborn baby's body, and don't have to worry about it, and it's not associated with any underlying disorder, and just no need to do anything for this. So after all this examination, now we come to the neonatal reflexes. So there are a few reflexes we should be able to perform it. Ideally, we should be doing it on the baby live, but anyways, I'll try that you will understand. So MOROS reflex, sucking, fruiting, plantar grasp, palmar grasp, stepping reflex, and the placing reflex. So the common neonatal reflexes. There are a lot more other reflexes, but we'll discuss just the important ones, which you should know at this level. So the MOROS reflex, also termed as the starter reflex. First of all, these as the pictures are coming. This is a rooting reflex. In the rooting reflex, what you do is just place your finger at the angle of the mouth, just touch it very gently, and you can see the child will open his or her mouth. So this is a normal reflex, and you should be, and it actually it's present at birth and usually lasts from 3 to 6 months of age, and it usually actually helps child to for breastfeeding. So this is a rooting reflex. You just touch the angle of the mouth, and you can see that the newborn will open his mouth. This is the rooting reflex. The sucking reflex, when you put the finger of your finger and touch it at the hard palate, the child starts sucking. So this is the sucking reflex. This is the MOROS reflex, also termed as the startle reflex. Now in the MOROS reflex, what you do, you just drop the head of the newborn at least 20 to 30 degrees, and very cautiously, by keeping your other hand beneath the head, just drop the head from one hand to the other at 20 to 30 degree level, and you can see because of the sudden drop, the child will act as embraced. First, he will open his arms and then close it. So first there is extension followed by the flexion of the arms. So this is termed as the MOROS reflex. It is also termed as the startle reflex, and whenever there is a loud sound, that sudden loud sound, in response to sudden loud sound, the MOROS reflex. Then the plantar grasp, when you put your finger from and move it from the sole of the foot towards the fingers, towards the toes, then you can see there is flexion of the finger toes and flexion of the toes. So this is termed as the plantar grasp. Then comes the palmar grasp. In palmar grasp, you keep your thumb, your finger in the palms of the newborn, and you will encircle his fingers towards your, encircles his palm towards your finger, and this is termed as the palmar grasp. Now is the stepping reflex. The stepping reflex, what you have to do, just touch the sole of the foot to any hard surface, and what happens, the child is trying to walk. He's flexing his other leg in an attempt to start walking. This stepping reflex is present at birth and usually lasts by 6 to 9 months of age till the child starts walking. So this is the stepping reflex. In stepping reflex, you have to touch the sole of the foot to the hard surface. You have to differentiate it from the placing reflex. On the placing reflex, what you are doing, you are touching the dorsum of the foot to the undersurface of any undersurface of the table. So you are touching the dorsum of the foot. Now, as you touch, the child starts to climb over this. It's again flexing it and trying to climb over this table. So this is the placing reflex. You have to make that difference. The stepping reflex, you touch the sole of the foot over the hard surface, while in the placing reflex, you touch the dorsum of the foot to the undersurface of the table. So that's all about the reflexes. You can ask questions after we discuss the last part of our talk. This is the gestational assessment. This is it seems to be a bit difficult part, but it's not as difficult as it seems. It's try to make it as simple as possible. This is actually just called the Ballard scoring, and this is a tool for assessment of the gestational age of a newborn baby. And why we use this tool? Because sometimes what happens that when you know that in our part of the world, most of the deliveries which are being conducted are unbooked case, and they come from the rural areas and they don't even know the gestational age of their babies. So how to go for it, because ultrasounds are also not available. So in that case, when the baby is there, you can use this gestational assessment tool, and you don't have to remember all these parameters, because this chart is available and you just have to follow this chart. And there are two components of this chart. One is the neuromuscular maturity and the other is the physical maturity. So there is a score given against each parameter, and what you do with each parameter, you just tick it whatever you find, and then at the end you sum of all points, and then this is the maturity rating scale you can see here, and in which one column shows the score, and it is telling you that in which weeks it falls. For example, if your score comes to be 22, now you can see here that 20 to 25. So your gestational age lies between 32 to 34 weeks. So it is an crude method of measuring the gestational age. It is not accurate, and because it's subjective, and it can vary between person to person, but it can give a clue to the gestational age of the baby. So we discussed briefly about the parameters. First parameter in the neuromuscular maturity is the posture. So you just have to lie the baby on the supine posture, and you see in what is the resting posture of the baby. You compare it with this picture. If your posture falls in this, or this, then you will mark accordingly. So the posture is quite simple. You just have to compare it with the resting posture of the baby. Now, square window. See, bracket mates written the wrist. So it is basically the angle between the forearm and the wrist. So you just flex the wrist and see what angle is made. You can see this, and this. The wrist can be moved like this easily, and you see that how much it could be flexed and what angle is made. So you can mark it accordingly. Then the arm recoil. How the arm recoil is performed? You flex the forearm at the elbow and then leave it, and then see in which posture it rests. First flex and just leave it, and see that what posture the child makes, and then compare it with this picture, at what angle is made. If it is like after releasing the flexion, if the arm goes in this position, this position, this position, this. So you mark it accordingly. Then comes the popliteal angle. It's very simple. You just extend the knee and see that what angle This comes in the antepopliteal area, and compare it accordingly. This is actually the back of the thigh. Then these calf signs. This calf sign, this is these dots showing the midline, and this is the arm of the child, arm of the baby. What you have to do is you have to touch the hand of the baby to the opposite ear. So bring the hand of the baby to the opposite ear and see what angles is made at the forearm, and just compare it. Whether you can bring the elbow across the midline, towards slightly across the midline, again across the midline, at the midline, not at the midline, or it's just slight movable. You cannot move it towards opposite ear, and you will again give the score accordingly. Then heel to ear. Heel to ear, you have to bring the heel of the baby towards the ear on the same side, and see what angle does he make and how much you are able to bring it towards the ear. All these maneuvers should be done very gently. You don't have to do it forcefully. And compare it accordingly and score it as it's required. So this is a neuromuscular maturity. You don't have to remember all these things and just know, you should know what are the parameters like posture, square window, arm recoil, popliteal angle, calf sign, and heel to ear. At least you should have an idea at this stage that how are you going to perform it. What is the benefit of performing this gestational assessment? And then physical maturity. Physical maturity is a bit easy. You just have to look at the skin. If it is sticky, friable, transparent, gelatinous, red, translucent, smooth, pink, with visible veins, superficial peeling, cracking, pale areas, parchment, deep cracking, leathery, cracked, wrinkled, then lanugo, non-sparse, abundant, thinning. Then third thing is the plantar surface, breast bud, it's imperceptible, barely perceptible, flat areola, stippled areola, raised areola, full areola. Then eyes and ears may, if the lids are fused, lids are open, pinna flat, slightly curved pinna, well curved pinna, formed and firm, instant recoil, thick cartilage, stiff hair. Then in the genitals, you have to look for the male, if the scrotum is flat, smooth, it's empty, testes in the upper canal, testes are descending, testes down, and testes pendulous. So you have to mark it accordingly. And the females, the clitoris is prominent, labia is flat, small labia minora, enlarging minora with prominent clitoris, majora and minora equally prominent, majora large, minora small. See what happens? In cases of preterm babies, the genitalia are not well formed, and the eyes and ears are also not well formed. The breast were very imperceptible, and so these physical signs are very helpful in maturity rating. So I hope that you understand the basic concept of the gestational assessment in newborns. And this is called the Ballard scoring system, which has two components: neuromuscular maturity. Even at this level, even you are not, we won't expect you to perform all these maneuvers, but at least you should have an idea that how are we going to perform these maneuvers and what is the benefit of this Ballard scoring system. It has two, you should know that it has two components: neuromuscular maturity and physical maturity, and the components of these two. Further breakdown of these components and how are we going to rate it. It will give you a rough idea of gestational age assessment. Obviously, it's not an accurate assessment. Okay, so now I'm going to take your questions. So if you have any questions, you can ask me. We have 15 to 20 minutes for question and answers. Okay, so there are few questions already asked. Please repeat the plantar flexion again. Okay, so this is the plantar grasp reflex. You just have to touch the thumb of your hand and bring it from the sole of the foot towards the toes. And you can see as soon as you bring it towards the toes start flexing. So this is the plantar grasp. And all these reflexes should be present at birth. If the baby is preterm, then the reflexes may be delayed, like plantar grasp, palmar grasp, sucking and muting reflex. They usually comes after 36 weeks of gestation. So if the newborn is delivered prematurely, then these reflexes are usually absent. And significance of MOROS reflex is that sometimes in certain damage to the brain, the MOROS may be incomplete. Like the baby can, or in cases of any nerve damage, like shoulder dystocia or Erb's palsy, any damage to the nerves, there is an incomplete MOROS reflex. The child is not able to move one of his arms or extremities. So this is significance of the MOROS reflex. MOROS reflex should be present at 36 weeks of gestation and usually lasts for 6 months of age. Okay. So any more questions? Can you repeat the time when a complete examination needs to be done? Okay. There are 3 assessments of the newborn. The first assessment should be done in the labor room. As soon as the baby is born, the first assessment should be done. And the second assessment should be done within the first 24 hours, because sometimes the baby may be normal at the time of birth and may develop signs of respiratory distress, jaundice, any other thing within the first 24 hours. So even if the first examination is normal, you have to revisit the baby within the first 24 hours of life. And the third assessment should be before discharge or within the first week of life. So these are the timing of the newborn examination. The complete neonatal examination should be done as soon as the baby is born. Not in the labor room, but within the first 24 hours. So I'm here to take your questions. We have 15 minutes left. Difference between hypoplastic auricle and the microtia. Okay. Let me tell you, you might see the picture. Now, this is a hypoplastic auricle. Now you can see here what happens, that the meatal canal is there and auricle is also present, but it's hypoplastic. See, auricle is there. Okay, but in case of microtia, there is no auricle, just meatus. You can see this, just the meatus is there. So this is the microtia in which auricle is not there. But hypoplastic auricle mein the ear canal is visible, but the auricle is malformed and the auricle is very small. So this is hypoplastic auricle, this is not microtia. In case of microtia, the auricle is absent, just meatal canal is there. I hope that you get your answer. You got your answer? Any more questions? So I hope that